Hello everyone, this is Kritika from Team Exercise Prescriptor. So in this video, I am going to explain a case study of one of our low back pain patients, like how we exactly diagnosed the condition and how we started the treatment program and what are the difficulties we have faced, and based on those how we modified the treatment and how we achieved the great progression. So this video almost looks like a case presentation, but I damn sure this video is definitely helpful to improve your clinical practice. So come on, let's dive into it. A 41-year-old male came with a complaint of low back pain for past 4.5 years, and his occupation is a product supplier. So he needs to bend forward, he needs to lift lots of weights like that, and the aggravating factor of the pain is this, and the relieving factor is rest. The pain intensity is 3 out of 10. And he lived with the pain for past 4.5 years, right? So we need to ask how he managed the 4.5 years and what happened in these years, because that plays a crucial part when it comes to outcome of the patient. So before 4.5 years, gradually he develops the low back pain, and also he felt a radiating pain in the left side lower limb fully. He visited multiple doctors and took X-ray and also MRI. MRI shows that disc height reduction, L5S1 disc bulge, nerve root compression, spinal canal stenosis like that. And also doctor advised that you should not bend forward. Hereafter you should not lift weights. You have to avoid the deep squat position, that is Indian toilet usage position. And also tell that if you are not avoiding these things, it will end up with a spinal surgery. So he develops lots of fear in his mind, and he searched a lot in the Google, and also he took some physical therapy treatments like dry needling, electrotherapy modalities, and somehow the pain was reduced, but still he's having the low back pain. That's why he came to us. So this was the entire story of the patient. Then we started the mobility and stability screening. In that, first we initiated with the forward flexion mobility, and it was very poor. He reached only up to the knees. And we checked the overhead squat. In the squat, visibly we have seen that shift towards the right side. So if the shift towards right side means obviously there will be an issue in the left side lower limb, but either it may be in the hip, knee or ankle. So isolatedly we have checked the hip mobility, knee mobility, ankle mobility, and we compare with the opposite side. Left side the mobility was reduced. And also isolatedly we check the muscle strength, glute, calf, everything we isolatedly check, and we compare with the right side. So left side muscles was weaker. And also we checked the SLR, crossed SLR, calf sneeze, everything was negative. So we rule out the radicular pain syndrome, and purely we diagnose this as a non-specific low back pain. Because in the past years he developed the radiating pain in the left side leg, and because of the doctor's advice also, he avoided all the physical activity and he refused to give weight in the left leg. So that's why the left side leg muscles undergone for weakness, deconditioning and mobility reduction, and this develops the asymmetry. Because of this asymmetry only, still he is having the low back pain. So we have started the treatment program, like isolatedly we strengthen the left side muscles, and also we have worked for the mobility isolatedly, left side hip mobility, ankle mobility, knee mobility, everything we work, and we make the patient to bend forward, lift weights, throwing the weights like that. And after few sessions, patient told that still I'm having the same pain, so there is no progression at all. And then only we realized that we asked the patient, we talked to the patient, we came to know that he's having lots of negative beliefs regarding the posture, low back pain, spinal cord, vertebra, forward bending like that. And also he always tells that I'm having the spondylolisthesis. Whenever I'm riding the bike, I feel the spondylolisthesis. And we educate a lot, but still he's believing that he's having the spondylolisthesis. Spondylolisthesis means slippage of one vertebra over another. MRI shows disc height reduction, right? So that's why he feels like this. And so we ask the patient to take an X-ray to make them believe that he is not having the spondylolisthesis. And after seeing the report only, he understood and he realized that, okay, I'm completely fine. I'm not having the spondylolisthesis. And while listening to the patient, we came to know that because of the doctor advice and all, he avoided to lift his own child. So how emotionally he's weak, right? So we address the psychosocial part more. We encourage the patient to do forward flexion, squat, lifting weights and all, because we are improving the load capacity, tolerance of the muscle. So nothing will happen. You can do all these things like that, be educated. Then only patient develops the great confidence and positive belief, and he progressed a lot and he told that my pain got reduced. So what I'm trying to convey from this is you should not always stick to the biomechanical part, and you have to address the psychosocial part of the assessment and treatment too. So without this, the treatment will be incomplete. So I hope this video has provided a great insight that how to apply the biopsychosocial model into your clinical practice. So if you like this video, subscribe to our channel and don't forget to share with your friends. Happy learning to all.